Can everyone hear me?
You sure are so tired. Hello. Hello, how are you?
Hello. Okay. Lisa, can you hear me?
Yes, can you hear me?
Yes. Barbara, can you hear me? Yes. No. But thank you.
We can come in, but we can't watch.
It's medical billing and coding.
What does that mean?
We're learning how to
I lose my shoes.
How did you do that?
They got muddy. Mine are wet. You have any shoes? Do you have a school nurse? Football here? Football.
Downstairs.
Down.
Okay.
Stairs? Stairs are right there. Elevator? Can I take the elevator?
That way.
Elevator?
That way.
You can stay where you're
Stairs.
talking about elevator. I'm going to take the elevator. I don't have a movie theater.
Doreen,
Yes.
did you get my email?
Barbara?
No, it's Lisa.
Okay, so Lisa, your picture's frozen, so I can hear you, but if I can't see you, I don't recognize the voice enough to know who's speaking to me, so
Okay.
tell me who's speaking.
Hi, Doreen, it's Lisa. Did you receive my email?
If it was today after 7 a.m., no.
No, I sent it right after class last week.
Probably. Did you ask me for resetting something?
No, no resetting. I haven't done anything on Evolve yet.
Okay,
But
that's okay.
it was that I'm missing.
You're missing which one?
I'm missing 4.
Hey Diane, it's on.
2014?
Yeah, I'm missing, the ICD-9, I'm missing HCPCS, the review book, and the reimbursement book.
Yes, okay, you have the Adams though, and I responded to that part of it.
I don't have the Adams.
You don't have the Adams or the Fordney?
No, I have the books that we're working on right now, and I have the step-by-step and the CPT. I have nothing else.
Okay, so which reimbursement book are you talking about?
I don't remember. It's in here in my notes. It's orange. It's the reimbursement. I don't remember it all, but it was very helpful before.
Okay, if it was the Adams book, I did get that email and I did respond. I said if it was the Adams book, you didn't need that one if you had the Fordneys. And everyone right now is waiting on the ICD-9, the HCPCS, and the review book.
Okay, so everybody's waiting. So I don't need the reimbursement book.
No, I don't even know which the reimbursement book is besides the Adams.
Yeah, it is the Adams book.
Okay, you don't need to worry about that one.
Okay.
Okay?
Yeah, I didn't see your email. That's why I must have gone over it.
That's fine. Now that you brought that up, it refreshes my memory. Okay, these are all the same. There we go. That way I'll get rid of the top of your head. Now no one can see you at all.
Thank you.
All they can see is the top of your head.
You're in the dark.
Who is?
You. As you scrolled down, you went darker.
Gardner High School is joining us. The lighting in here is they put us in a different room this week. Okay. But you can hear me okay?
Yes.
Okay, because I'm across the room, so I don't want to have to yell too loud. Okay. Okay, so welcome to, I believe we're on week 4 in coding. And we're continuing on with the Fordney's book. And you were to read 12, 13, and 14. And I gave you exercises to do, I believe, in 9, 10, 11. Is that correct?
Yeah.
We can go over those.
I had a hard time with 12, the math.
Well, 12, 13, 14 exercises would be for tonight. Right? Did I get, okay. All right. Let's do roll call first. Has he changed at school? All right, today is 11/6. Okay, and then we have Lisa online.
Yes.
And Bob Hanky.
I'm here. Here.
Thank you. And I saw Gardner. Is there anyone in Gardner or just an empty room?
Yep, it's Angel LaBelle.
Okay.
It's showing the door for some reason.
You can turn it, move it.
By hand or
Yeah.
hand?
Do you have a Tanberg or is it?
I think it's Danberg, yeah.
Okay, so yeah, you can just move it.
Which one do I use? What
If
button?
Is it mounted on the wall?
It's on the Danberg itself.
Oh, well,
The screen.
you can
Yeah, it's
actually
got a. It's,
change the angle of
oh.
it.
Oh. Hold on, it's doing 2 now. Cancel. There we go. I can just move.
Yeah, you just use the arrows on the remote and it will move it.
Oh, no, it's bringing up another one.
That's okay.
Over, yeah.
You're going the wrong
Yeah.
way. There you
I
go.
see that.
Okay, now down.
There
Go.
we go.
There we go.
Oh,
Up. Perfect. Excellent. Good job. Okay, and that's all we have. No Darla. Lisa Leonard should be coming from Noble. Christina, we don't have her. She missed the last 2 classes because of work, so I know that. But okay. All right. Yeah, Darla is usually doing mine. Okay, so, all right. Let's go over the answers for chapters 9, 10, and 11 in the study guide. I believe I had you start on page 161. We were filling in the blank. And just to reiterate, everyone is still waiting on HCPCS, ICD-9, and probably your CPC exam physician review book. If you don't have your CPT book, you should have that sooner rather than later. And you're all lucky because I don't have any of mine. Okay? So you're luckier than I am. And I did. I sent out another email to Elsevier and Amy today asking about the status of the books. So here we are, the first week of November. It's not unusual to not have the ICD-9, the HCPCS, and the exam review book, just because that is when the updates have happened. Literally, the publishing probably finished the last week of October. So now they are in a rush to get all of the orders out. Okay, so the fact that you even have your CPT book is a plus. And if we have to start with CPT before we start with ICD-9, then so be it. No big deal. Okay, so fill in the blank. For number 1, we want to name the provisions seen in health insurance policies. What is the first one, Emily?
The claimant has an obligation to notify the insurance company of a loss within a certain period of time, or the insurer has the right to deny benefits for loss.
That's right. So it is up to us, the insured, to notify the insurance of a loss of a claim pretty much in a timely fashion. You don't want to wait, a couple months and then report a loss. Then the next one would be if the insured is in disagreement with the insurer for settlement of a claim, a suit must begin within 3 years after the claim was submitted. So that's not too bad. And then the insured person cannot bring legal action against the insurance company 60 days after a claim is submitted to the insurance company. And then the fourth one, the insurance company is obligated to pay benefits promptly when a claim is submitted. Okay, so those are your provisions seen in health insurance policies. Those should be clear in your book. Number 2, after an insurance claim is processed by the insurance carrier, a document known as what is sent to the patient and to the provider of medical service. Hello, Lisa. Glad to have you with us. We missed you.
I missed you guys too.
Okay. Excellent. We are just starting on the homework on page 161 in the study guide. Page 161 in the study guide, fill in the blanks. Number 2, the answer is going to be explanation of benefits. We've all talked about those last week. And I think I gave you some examples in the book of what it might look like. All right, number 3, name other items that indicate the patient's responsibility to pay that may appear on the document explaining the payment and check issued by the insurance carrier. So we have A through F. What is A, Teresa?
I wasn't clear on this one, so I'm guessing I did the not covered.
Yes, amount not covered. Perfect. B is what, Emily?
I didn't do this one because I had a hard time understanding what the question was.
Co-payment amount. Okay, so let's break it down. Name other items that indicate the patient's responsibility to pay that may appear on the document explaining the payment and check issued by the insurance carrier. Okay, because we haven't really gone into this particular area in depth, I'm not too worried about it. Remember, all the answers that you do here in the Fordney book is practice, because we're going to be pulling it all together at the end, okay? And I'm actually going to bring in some EOBs and, black out the demographics and patient ID and stuff like that, so you can actually see some different examples of explanations of benefits. But what they, go ahead.
No, I was just going to place I got these answers because I wasn't sure either. I just went across this black.
Perfect. So on what page?
300.
So on page 300 in your textbook is where Teresa found her answer for number 3. So if you look, if it's the patient responsibility, it's going to say amount not covered, co-payment amount, it might be deductible, co-insurance, other insurance payment, or patient's total responsibility. Okay? Number 4, after receiving an explanation of benefits, also known as an EOB or an EOMB, document and posting insurance payment, the company of the insurance claim form is put into a file marked closed claims. Now, I don't go that far. I just create, as I mentioned early on in the class, a daily bundle, and it gets put into a file folder by month, and then at the end of the year, I purge everything and I put it into a box and I just mark the box. Now, if you have issues with claims, you're going to create a copy of that remit so that you can work it, what I call work it. And what does work it mean? It means that you're going to call the insurance to find out why it's denied. What do you have to do to resubmit it? So then you take the action that you've been told that needs to be done to rework that claim and get it resubmitted. And then you put it back in your tickler system until it comes in so that you can follow up on it if it doesn't come in within, say, 30 days, because it's usually 30 days. And then comes that 30 days, you look and you pull it out and you check in your system, has it been paid or do you need to call on it? You just keep moving it forward in your tickler system until it's resolved. And then what I do is I have a resolved claims folder. I put them in the folder alphabetically, so it's easier to find them alphabetically, rather than by patient account number. if it's a PI or workers' comp folder, I create totally separate file folders with the patient's name on it, and I call that my working folder, so that anything and everything I do regarding billing for that patient goes in that working folder. All right, number 5. What would be the answers for number 5? What do you think? Angel?
Under date claim column.
Yes, date, claim, paid column, and then would it appear blank?
Oh, yeah. And if blank, check date, claim submitted column, and follow up as needed.
Okay. All right, number 6. Name some of the principal procedures that should be followed in good bookkeeping and record keeping practice when a payment has been received from an insurance company. So you're going to pull all of the copies of the insurance claims that correspond with the payments, and you're going to dispose of them. You're going to post the payment to the patient's financial accounting record and to the day sheet and deposit the payment check in the bank account. First of all, you don't dispose of them. I don't care if they're copies. Okay, you can keep the copies in your working folder if you want, so that if for some reason you need to have those copies, you can pull them all together all at once. You don't shred them or dispose of them until that case is completely resolved. And you still should keep everything for at least 7 years. Number 7, in good office management, a manual method used to track submitted pending or resubmitted insurance claims is a what? What do you think, Lisa?
3x5 index cards.
You can use that, and you would call that what?
Tickler.
A tickler, a suspense, or a follow-up file. Okay? Now, go over to page 163, multiple choice. Right? Okay? If the insurance carrier is a self-insured plan, a Medicaid or Medicare health maintenance organization, or an Employee Retirement Income Security Act based plan, the insurance commissioner is what? What do you think, Teresa?
I put B, is not able to assist with carrier issues.
Correct, B. Okay. 21. What is the answer to 21, Barb?
I put D, all of the above.
Yes, correct, D, all of the above. And 22, Lisa?
I didn't get that one.
22. An insurance claim transmitted to the third-party payer that is rejected because it contains a technical error such as missing insured's birth date is also known as a soft denial. What is a soft denial? Basically, a soft denial means that it never even got to the payer. It got scrubbed by your clearinghouse or your software first. That's a soft denial. 23. When an electronic claim is transmitted for several services and one service is rejected for incomplete information, the solution is to what? Angel?
B.
Actually, it's C. Add the required information and retransmit the rejected claim.
Right.
All right.
I had that one originally and then crossed it off.
Second guess yourself. That's what you every single time. Every single time. 24. A request for payment to a third-party payer asking for a review of an insurance claim that has been denied is referred to as a what? Teresa?
B.
Appeal?
Yes. B, appeal. All right, trues and falses. 26 is true. 25 is true. On page 164 in your study guide. 26 is true. 27 is false. 28 is false. And 29 is true. Now let's turn to chapter 10, page 185 in your study guide. And we did some fill in the blank. Emily, how'd you do it this way?
All right.
Okay, you want to answer number 1 for me, please?
For private insurances, government plans, managed care contracts, and workers' compensation.
Yes. The third party payers are composed of your private insurance, your government plans, your managed care contracts, and your workers' compensation. All right. Would you answer number 2 for me, Lisa?
Which one?
Number 2,
A&R?
the unpaid balance, yes, is known as an accounts receivable. Number 3, Barbara.
This could be a patient registration form or a patient information sheet.
That is correct. Number 4. Number 4 is a courtesy adjustment. Now, be careful though, because since your adjustments occur for many different reasons, not all of your adjustments are labeled courtesy adjustments. So I actually have several different labels in my software programs that actually indicate work comp adjustment, self-pay adjustment, Anthem adjustment, Aetna adjustment, so that I know which insurance is adjusting, and then the courtesy adjustment. Number 5, Teresa.
Verify check, ask the patient for driver's license and another form of ID.
What other form of ID do you think is appropriate to ask for?
Credit card, mailing address, bill.
Credit card, a bill, something else that has their name on it that matches them. Okay, number 6, Lisa.
Age analysis?
Yes, age analysis. Number 7, write the formula for calculating the office accounts receivable ratio. What you would do is divide the month-end accounts receivable balance by the monthly average of the medical practice charge for the prior 12-month period. So if your typical charge for the past 12-month period is $150, you would divide your total AR, your month-end AR balance by that monthly average. And that would give you a ratio, percentage of. But the programs out there nowadays calculate all of that for you. So a lot of this manual stuff that we're learning, we don't have to do, but it's good to know how to do it. So number 8, what is the collection rate if a total of $40,300 was collected for the month and the total of the accounts receivable is $50,670? What'd you come up with, Angel?
That's what I'm confused on that altogether.
What'd you come up with, Lisa?
But
I'm with her. I was confused too.
I mean,
Lisa? Okay.
Do you just subtract that?
Okay. What'd you get, Teresa?
Well, I didn't put my decimal point in the right place. I did .01.
What'd you get, Emily?
Oh, 1.26.
It's actually 80%.
80%. I didn't even do this.
Okay.
I divided
Me too.
the accounts received. I did it wrong by the collection rate.
So, when determining your collection ratio, just keep in mind that usually your several months collection is the total accounts receivable. That's what's considered to determine the collection ratio, and not usually only 1 month's collection. Okay? So yes, you should have been able to divide one into the other and come up with the 80%. I believe I don't have a calculator. Okay? Yeah, I believe it's divide the collected. Whoever has a calculator can figure it out for me, but
I just did it. It's the 50 into the 40,000.795, and you round up to 80%.
perfect. Thank you very much. So, got it? Excellent. Number 9, what are the physician's patient accounts, single entry accounts, open book accounts, or written contract accounts? They are open book accounts. A court order attaching a debtor's property or wages to pay off a debt is known as a garnishment. You know if you have stickies? I just use one. Thank you. Yeah, I did not come prepared. An individual who owes an account and moves, leaving no forwarding address, is called a skip. Translate these credit and collection abbreviations. Lisa Leonard, would you do me the honors, please?
I thought we only had to do part 2, so I didn't get that.
Yeah.
Oh, yes, thank you. Okay, so part 2, mix and match. Hold on. You guys can keep me on toes.
Actually, I'm not sure.
Yep.
What's sort of question 14?
14,
Are we doing?
chapter 13.
Number 14. On 100.
Yeah,
What is it?
chapter 13.
Okay. I did get it.
Okay, you mix and match. Okay, 17. First one is D. Second one is G. Then we have H, A, I, E, B, F, C. I need to repeat them. Okay. $18, you should have C, D, E, A, and B. $19 would be the letter D, forgery. 20 would be forwarding service requested. 21 would be D, all of the above. 22 is A, credit counseling. 23 is B, restrictive endorsement. And then 24 is true. 25 is false. 26 is true. 27 is false. And 28 is true. Got it? Page 215 in your study guide for chapter 11. That is the right time.
No, it's not, I don't think.
Oh, it's 6 o'clock. It's not 7.
Yeah, it's an hour.
Mm-hmm. I wonder where that classroom is.
The yoga class.
Next door. We have yoga going on next door. All right, so fill in the blanks, 1 through 10. The answer for number 1 is what, Lisa?
Capitation.
It is capitation. Number 2, Lisa Leonard.
Closed panel program.
Yes. Number 3, Angel.
The one I didn't do.
Just guess.
I don't know. A primary care physician?
Close. It's a gatekeeper. Your primary care physician
Gatekeeper.
is a
Same,
gatekeeper.
different name.
Number 4, Barbara.
An HMO.
Yes, HMO. Number 5, Emily.
A prepaid group practice model, a staff model, a network HMO, or a direct contract model.
Yes, number 5 would be prepaid group practice model, staff model, network HMO, and a direct contract model. Excellent.
Sorry.
Number 4 is health maintenance organization, or HMO.
Thank you.
Number 6, Teresa.
FMC, Organization of Physicians, sponsored by a state or local medical association, concerned with development and delivery of medical services and the cost of health care.
Yes. An organization of physicians sponsored by a state or local medical association concerned with the development and delivery of medical services and the cost of health care. Okay. Number 7, you have 2 types of operation. The first one is a comprehensive type, and the second one is a claims review type. I'm not going to read those out. If you want, you can find them in your book. Number 8 is a PPO, or preferred provider organization. And number 9 is a POS, or a point of service plan. Number 10 would be IO, or Quality Improvement Organization. Who was asking a question? All right, let's move on to multiple choice. Number 14, all of the above. What do you have for 15, Angel?
B.
Yes, 15 is B. 16, Barbara?
I had A, carve-outs.
Yes, A, carve-outs. What do you have for 17, Lisa Leonard?
A, direct referral.
Actually, 17 is going to be verbal referral. Letter D, verbal referral. And 18 is what, Lisa Fry?
C.
Yes, C, network facilities. Are true and false? 19 is true. 20 is true. 21 is false. 22 is false, and 23 is false. Now, I had you complete the treatment authorization form. So, you were supposed to use page 221 and 221 in your study guide, right? In order to help you fill in the authorization form on 219. So up in the top right-hand corner, what did you have marked, Emily?
I need a referral.
It's a referral. And what is the patient's name, Teresa?
Meriwether Riva,
Yes. And what is the date?
08/02/14.
Yes. And we have a female, age 45. Her FHP number is A4932. Her home phone number is 555-263-0911. She lives at 207 Blake Street, Woodland Hills, Texas, or XY 12345. Her primary care is Gerald Practon. Her primary care MD's FHP number is FHP C01402X. The referring MD is Gerald Practon. His referring number would be the same as the primary care number. He is referring her to Victor Salazar, MD. The address is 20 Excalibur Street, Woodland Hills, XY 12345. Office phone 555-625-7344. This would be an other type of service. The clinical history and findings: normal blood pressure, abnormal heart sound. Diagnosis: murmur. They actually put an ICD-10 code of R01.1. If you didn't get that, don't worry about it. Evaluation, treatment to date, clinical history, and physical exam. Procedure would be none. The CPT code, you would have 99243. The reason for the referral would be recommend consult to Dr. Salazar, cardiologist, for heart murmur. Accident, no. It is semi-urgent, and underneath facility to be used, office, put a check or X in office. How'd everyone do with that? Pretty good?
Okay, Doreen, this is Barbara.
Yes.
A physical exam doesn't count as a procedure?
No. Because 99243, if you look that up in the CPT book, that's part of an exam. I forget what it is, but 99243 follows on your E&M codes.
Oh,
And
okay.
I have the CPT book with me tonight, so if you have one there, look it up and tell me what it is.
So, can I ask a question, Doreen?
Sure.
It's Lisa. I
Yes.
wrote down detailed history, detailed exam, low complexity medical decision. Was that right?
You didn't really need all of that, but that's fine.
Okay. Thank you.
You're welcome. Did you find it, Barbara?
No.
I believe it's in your E&M section. And it is an E&M code, so it would be in the first part of the CPC book, not in the back. I'll be able to address that.
What is the code you said it was?
99243.
It is on page 20. In your CPT book. Did you find it?
Yes, so this is an office consultation,
Yeah.
which needs 3 key components: a detailed history, a detailed examination, and a medical decision. So he did all that.
Correct.
So why wasn't why did you put none for procedure?
Because he didn't have an actual procedure. The E&M in itself, yes, is a procedure, but above and beyond the exam, he didn't perform any other procedure.
So, all right, so it all just comes under being called this office consultation.
Yes.
Okay, but if he did a heart test or something, EKG or something,
Then that would be
then that could be a procedure, right?
Yes.
Okay, thank you.
All right. Note to self, ask for whiteboard. At some point, we're going to be using it, so I did that. All right, so page 12, I'm going to talk lovely care. Okay, so with Medicare, with any insurance, on page 399 in the textbook, you want to explain to the patient to bring their insurance card with them. Okay? So part of your new patient phone call, your scripting should say, so remember, Mary, to bring your insurance card so I can make a copy of it, and a method of payment, and your day planner so that we can collect your payment for your services and make your next appointment. But always remember to remind the Medicare patients. Now, a lot of Medicare patients, they've had this little paper card in their wallet forever, and it's worn and probably hard to read. So when you make a copy of it to put it into their chart, make sure if you cannot read it, if it's all blurred, at least hand write the numbers underneath the card. Okay? I can't tell you how many times I have a copy scanned into a patient's chart, and it's either cut off the beginning, you know, it's copied way over to the edge, so it's cut off the first digit, or it's so blurred that even with a magnifying glass, I can't make out the numbers. And believe it or not, if you can't read it, I can't read it. look, hello, I need glasses. It makes all the difference in the world, because if one digit is off, say you think that this is an 8, but it's really a 3, or 4 is a 9, or a 7 is a 9. Believe it or not, that one digit will delay a claim forever if you're not paying attention, okay? And if no one picks up on it. Because at the front desk, you're supposed to be doing your job, and then as like the therapy assistant, you're doing your job to review the information, and then as the billing person in the back, I'm doing what I'm supposed to be doing in the back. So before that claim even goes out the door, we've handled that patient's information umpteen times. So between the 3 of us, all of us should be getting it right. But if all 3 of us get it wrong, we're in trouble.
Can you call their insurance company and verify the information for them?
You can.
Depending on their age and stuff like that?
Absolutely. With chiropractic and the majority of Medicare patients, what you need to know is that they have a deductible every year. And it's usually $150 or less. And so the patient just needs to meet that deductible every year. And then they're responsible for 20% after services. After Medicare pays their 80%. So it's really important that the name on that card is also entered into the computer as it is on the card, okay? So if it's Mary S. Robichaud, then make sure you have an S and not an F. Or don't put Mary Robichaud, because they will deny just Mary Robichaud, because that's not how the name is on the card, okay? You can identify the benefits or the non-benefits if you want to. They have a new IVR system now, which really helps, tells you if there's a secondary insurance and if they've met their deductible. So that's nice. You don't have to actually talk to a live person if you don't need to. Also, I know the new Medicare website has really improved as far as going online and being able to check some eligibility for the Medicare patients. So policies and procedures, or policies and regulations around Medicare, over on page 400, are administered by the Centers for Medicare and Medicaid Services Division, otherwise known as CMS. We also have the Center for Medicare Management, which does what, Emily?
Oversees traditional fee-for-service Medicare and policy management of fee-for-service plans.
It oversees. Center for Beneficiary Choices is what, Barbara? The Center for Beneficiary Services actually provides beneficiaries with information on Medicare. And then the Centers for Medicaid and State Operations, it focuses on your federal and state programs. And then also keep in mind that CMS enforces the insurance portability and transaction and code set requirements for HIPAA. So, your eligibility requirements. As I said from the very first class, a lot of what we're hearing in the Fordney book will be repeated in the Buck book. And it's all right, because what we're learning bears repeating, only because this is going to be your foundation for the rest of the class. This is one level of the foundation that we're starting to build. So people 65 who are retired on Social Security, that's one of the requirements. People 65 who are retired from railroad or civil service. You don't see many railroad Medicare patients out there anymore. If they are, that would give them an eligibility. Children and adults who have kidney disease, those are eligible, and any kidney donors. If you look at the health insurance card over on page 401, you'll see this is what it looks like. It's just red, white, and blue. Literally, red, white, and blue. And you're not even supposed to laminate it. They say you're not supposed to laminate it. Medicare Part A, over on page 402. Medicare Part A is your hospital benefits. It covers you for the hospital up to 90 days, in a nursing facility up to 100 days. It covers your home health care services, your psychiatric hospital, your hospice care, and your respite care. Part B, over on 403, covers medical expenses, your clinical laboratory services, your home health care, your outpatient hospital care, and lab work. Now, if you turn to the tables on page 404 and 405, these are all the coverage requirements and limitations. So it basically tells you in one column the coverage, what does Medicare pay in the next column, and then what does the patient pay in the last column. So if we look at occupational therapy over on the right-hand side, guess what? Medicare pays 100% of the approved amount after deductible. What do you think that means, Lisa Leonard?
I think it means you pay the whatever deductible, 150, whatnot. Once you hit that, they pay for everything after that.
Right.
For occupational therapy.
Right. Yes, that is correct. Okay, Medicare Part C. Medicare Part C Advantage Plan, or the Advantage Plans, as I like to call it. You will find that the Advantage Plans are available in HMOs, your POSs, your PPOs, your PFFS, your PSOs, your RFBSs, and your MSAs. And if you want to know what all those mean, you should have read the chapter. It's just an acronym for the different types of plans. What you will see as an Advantage Plan would be Aetna has a Aetna Medicare Complete. United Healthcare has a Secure Horizons. United Healthcare also has an AARP Medicare Complete. Your Humana plans, your Martin's Point plans, your Today's Option plans. There's even, oh goodness. Those are the ones I can remember off the top of my head right at the moment. But those are all Advantage plans. Now, Advantage plans, basically what they do is they take over for Medicare. So if someone comes into the office with an Advantage plan and they say, here's my insurance card and my Medicare card, you have to bill Medicare first. No. The Advantage plan becomes primary because the Advantage plan takes the place of Medicare. It doesn't mean they don't have Medicare anymore. It just means they got the Advantage plan to cover services better than what the Medicare plan actually did. Which means they opt out of that part of the plan for Medicare, and the Advantage plan takes over. So you would actually build the Advantage plan, not Medicare. Very rarely would you bill Medicare when someone has an Advantage plan. I had it just happen probably the past 2 weeks. I had a patient come in and they have U.S. Family Health. It's actually out of Martin's Point, but U.S. Family Health Plan does not cover any chiropractic. So in that instance, I am able to bill Medicare for the chiropractic services, and the patient will be responsible for any of the co-insurance left over. In other instances, I would bill directly to the Aetna Medicare Complete, the Humana, and so on. Okay? Medicare Part D, this is your prescription drug benefit. It is effective January 1st, 2006. It is eligible for Medicaid and Medicare member, pays no premium or deductible. It is a tiered drug plan, and you want to make sure you check Medicare information for authorization requirements. And you see that there's a lot of Medicare Part D plans out there as well, just like your Advantage plans. The railroad retirement benefits on the next page, 408. The railroad retirement benefits, your medical insurance premiums are automatically deducted. It entitles the beneficiary to covered services at a qualified American facility. And some of the members may be of the Railroad Hospital Association. They might have prepayment plans or contracts with Medicare. Again, you do not see a lot of railroad plans out there right now. Why? Because the members of that age have passed away. Your employed elderly benefits. The federal laws and regulations that you will see around the employed elderly benefits will be OBRA, which is the Omnibus Budget Reconciliation Act. Also, the Tax Equity and Fiscal Responsibility Act, the Deficit Reduction Act, the Consolidated Omnibus Budget Reconciliation Act, and the Tax Reform Act. What is the Tax Equity and Fiscal Responsibility Act? Mr. Leonard?
Sorry, I said it all and the microphone wasn't on. I'll go through it again.
Thank you.
The Tax Equity and Fiscal Responsibility Act, TEFRA, of 1982 established that an employee or spouse aged 65 to 69 years is entitled to the same health insurance benefits offered under the same conditions to younger employees and their spouses. The group insurance is primary and Medicare is secondary. TEFRA applies to the employees with at least 20 full-time or part-time employees.
Very good. And the Tax Reform Act, what is that, Angel?
Clarified certain aspects of COBRA. A spouse and dependents may elect to receive continued coverage even if the employee does not wish insurance coverage and terminates the plan.
Very good.
So it covers your family and you if you're terminated.
Some additional insurance plans. You want to determine if Medicare is primary or secondary, which I've been talking about. Ask about other insurance. Copy their Medicare card. Ask about the supplemental coverage. Call the carrier and bill directly. So when you're in a practice, when you're in the office and you're asking the patient, now every January we go through this, we ask the patient if their insurance has changed. Why do you think we do?
Most insurance change.
Yes. Most insurances change yearly. The card might not change, but the benefits might change. So it's a lot easier for us to just keep track of whether or not we called by just getting a copy of the card and making phone calls on those benefits, okay? The plans that usually change the most are your Cignas, your Anthem, the Harvard Pilgrims, the health plans, any plans that have high deductibles, okay? Maine Community Health Options, they came out this year, they actually have high deductibles. They follow the tiers like the Anthem plans do, all right? So you have to say to the patient, Mary, I understand last year you had Medicare and AARP. Did you make any changes to your insurance this past year? Especially over the year, and they're coming and going, you know, they're talking about things, and you kind of remember in your mind, I gotta keep an eye on that one, because I know she mentioned she might be changing insurances. So I just found a patient this past week that I've been billing their secondary insurance has been denying, and I was covering the front desk, and I said, you know what, Mary, your secondary is not picking up for some reason. This is what I have for your secondary. Is this what you still have? And she's like, no, I have a whole other plan. And I called her, and it was over a year old. So she's had this plan for a year, and
Nobody's asked for a copy.
Yes, I kept asking the front desk, please ask this patient to, you know, and she says, yeah, they've been asking me if it's been changing, and if it's changing, and I keep telling them, no, it hasn't. I says, well, that's probably because they didn't ask you, do you still have Anthem? She didn't have Anthem. She had the new Maine Community Health Options. And I'm like, oh goodness. Okay, so, not a problem. I'll take your information, I'll get it cleaned up, and I'll resubmit the claims. But you have to be specific. You have to, you know, kind of guide these patients to get the answers that you're looking for. Okay? Crazy. I found out so much these past 2 weeks covering the front desk, it's not even funny. I have so many stories that I can share in class. Medicare Managed Care Plans. They are your HMOs over on page 410. They are your risk plans, your cost plans, and your carrier dealing prepayment organization. What is a carrier dealing prepayment organization? Barbara? Over on page 412.
This organization may be set up by a medical practice under contract to the government. They're considered a service contract rather than insurance. Such plans were run by HMOs, but now practices of 12 to 15 physicians are opting to run their own plans. These organizations must be incorporated and have their own Medicare provider number. They must furnish physician services through employees and partners or under formal arrangement with medical groups, independent practice associations, or individual physicians.
Very good. Okay, the risk plan. The beneficiaries receive Medicare-covered services from providers who are contracted members of HMO network. Your enrollees are actually called restricted beneficiaries. Utilization and quality control on page 412 in your textbook. Your quality improvement organizations. Contracts with CMS. You have a contract with CMS. They have the right to review your medical necessity, the reasonableness, the appropriateness, and the completeness and adequacy of care. Utilization and quality control also underneath that falls the Federal False Claims Amendment Act. Lisa Fry, what is the Federal False Claims Amendment Act?
I'm looking, but I can't keep up with you. Keep changing the pages.
Page 412.
Okay.
Federal False Claims Amendment Act, bottom of the left-hand column.
Right. It just says fee for service plans, and is that the one you're looking at?
Federal False Claims Amendment Act, another federal law to prevent overuse of services and to stop Medicare fraud, is the Federal Claims Amendment Act of 1986. Page 412 in your textbook.
Oh, it's right there.
Okay. Clinical Laboratory Improvement Amendments. What is Clinical Laboratory Improvement Amendments? Angel.
Establish federal standards, quality control, and safety measures for all freestanding laboratories, including physician offices, laboratories. Various laboratories fall within CLIA categories depending on the complexity of each test.
That's good. Okay. On page 413, we're going to get into billing and some of the Medicare billing compliance issues. This is a HIPAA compliance alert. Because Medicare is a federal program, legislation sets down the policies that must be followed. Therefore, whoever participates in the program must comply with all the regulations. Billing issues about which medical practices should be aware may include, but are not limited to, the following. Can you read those for me, Emily, please?
Release of medical information, reassignment of payment, limiting charges for non-participating providers, correct procedural code assignment and service utilization, accurate and realistic code assignment, medical necessity of services performed, billing for
ancillary,
employees, physician assistants, and nurse practitioners, called incident billing, documentation related to selection of procedural codes for services performed, again, orders and supervision requirements, teaching physician and resident billing, routine waiver copayments, deductibles, or professional courtesy discounts, Start 1 and 2, anti-referral and compensation regulations, credit balance refunds, and correct coding initiatives, CCIS.
exactly. All of that good stuff. Which is everything that we've touched upon already this far in the book. Okay? And really, it's not just about Medicare compliance, it's about compliance across the board. Okay? Payment fundamentals. What is a participating provider, Teresa?
Participating
Physician.
agreement. A physician agrees to accept payment from Medicare at 80% of approved charges, plus payment from 20% of approved after the 140 deductible in 2012.
Yes. So a participating provider is also known as a PAR provider. Your non-participating provider does not have a signed agreement with Medicare and has an option about assignment. The physician may decline assignment for all services or accept assignment for some services and collect from the patient for other services performed at the same time and place. An exception to this policy is mandatory assignment for clinical laboratory tests and services by physician assistants. Unassigned electronic claims that are denied have no appeal rights. Your non-PAR physician receives only 95% of the Medicare approved amount. Your non-PAR physicians may decide on a case-by-case basis whether to accept assignment. If the non-PAR physician accepts the assignment for a claim, Medicare pays 80% of the non-PAR Medicare approved amount directly to the physician, and the physician collects the remaining 20% from the patient.
Doreen, this is Barbara. Could you give me like an example of what would be something like the doctor would agree to and then something he wouldn't?
Basically, it would just be that the provider doesn't want to participate. I don't know of any provider who would do a case-by-case basis.
Yeah, that doesn't make sense. It's like just be in the program.
I don't know of any provider who would do it. I know of providers who are either in or out. It doesn't benefit you to be in and then accept things and not accept things. But keep in mind, whether you're non-par or par, you're still held to the same standard as being a participating provider. You still have to have the same documentation. You still need to follow rules and regulations just like a par. So, if the non-par physician does not take assignment on a particular claim, he or she may balance bill the patient 115% of the non-par rate because Medicare will send the payment to the patient. So for example, if the non-par rate is $100, the provider can balance bill the patient for $115. However, in this case, even though the physician is required to transmit the claim to Medicare, the carrier pays the patient directly, and the physician therefore must collect his or her entire fee from the patient. Thus, the physicians must chase the money. Basically, what you do is you tell the patient up front, this is a non-covered service, payment is due at time of service. And you get them to pay up front, or at least put a portion on their bill. Limiting charge is a percentage limit on fees, specified by legislation that non-par physicians may bill Medicare beneficiaries above the allowed amount. Your non-par physicians may submit usual and customary fees for assigned claims. Because of these two situations, non-par physicians usually have a fee schedule that lists both usual fees and limiting charges. Some states have set limiting charges that are more restrictive than Medicare policies. These states are Connecticut, Mass, New York, Ohio, Pennsylvania, Rhode Island, and Vermont. So you would actually need to go to the Medicare guidelines for those states. Okay? So, is it benefit to be non-par or par? If you're participating, you get paid quicker, and if you're non-par, you get paid slower, and you always have to go chasing the patient for the money. Prior authorization for Medicare patients who have additional insurance. Their Medicare will pay a certain percentage, and the secondary insurance should take care of the difference. There are mandatory procedures that need prior authorization. They show you here what that prior authorization is. Over on page 415, you see a copy of a claim form. Now, somewhere in your paperwork, when you have the patient sign paperwork, they should sign something that says something similar to box 12 there on the claim form. Can you read what that says for me, Angel?
Yeah. Patient's or authorization person's signature. Read back a form before completing and signing this form. And then it says signature on file.
Right. So, box 12, and then down below, where it says accept assignment, there's an X in the yes. That means that we, as the participating provider, accept assignment, which means we get paid directly. When the patient signs in that box, what we do in our software program is we mark the program so it shows signature on file. Now we can either put signature on file or we can say print the patient's name. Signature on file is accepted. Turn the page to waiver of liability provision. There is an ABN. An ABN is also known as Advanced Beneficiary Notice of Non-Coverage. They show you an example on page 417. You have the patient sign it if you expect Medicare to deny the payment entirely or in part. You want to refer your NCDs and your LCDs, which are your local coverage determinations or your national coverage determinations, and find out which services actually require an ABN. And every specialty would fill out the ABN a little differently. But you can see there, they have 3 options that they would need to fill out, one of those. Your prepayment screens on the next page. Medicare limits the number of the time procedure can be billed during a specific time frame. Again, your billing guidelines will tell you these things. Your computer screen can trigger a suspension of processing if it comes up upon a procedure that has been billed too many times, the patient's had too many visits, if the frequency is inappropriate, and so on. Medicare reimbursement. Tell me about the chronology of prospective payment system. What is that, Lisa Leonard?
I'm just reading through it for a minute.
That's fine.
I'm just going to read it out loud because I'm not really understanding the words.
Just give me the first sentence.
Okay. Medicare payments were based on reasonable fees. For example, the amounts approved by MAC.
Yep.
Medicare paid 80% of the approved charge. On October 1st, 1983, an important development in the Medicare Part A program, the PPS became effective. Under the regulations enacted by Social Security Amendment of 1983, hospitals treating Medicare patients are reimbursed according to pre-established rates for each type of illness treated on a basis of diagnosis. Payments to hospitals for Medicare services are classified according to more than 700 diagnosis-related group DRG numbers.
Okay, stop right there. So basically, the prospective payment system comes down to this. They set up fee schedules. And basically, they gave fee schedules to every type of procedure code attached to certain diagnoses. And depending on where you live and what type of procedures are being done, there is a payment system that allows the providers to be paid up to a certain reasonable and customary or an allowed amount. Okay? So reasonable fee is just that. It's an amount that Medicare deems as reasonable. Date 420. Resource-based relative value scale. These are your RVSs. We'll get into that in the Buck book. Your HCPCS. We'll go over the HCPCS, the Healthcare Common Procedure Coding System. You will actually be getting a book. The Physician Quality Reporting Initiative, PQRI. Teresa, what is PQRI?
It's pay for reporting program for providers who bill under Medicare Part B. This financial incentive program is for eligible professionals who choose to participate and successfully report on a designated set of quality measures participating under the Medicare physician fee schedule furnished between specific dates.
Yes, so let me give that to you in little different way. PQRI or PQRS. It's Physician Quality Reporting Initiative or Physician Quality Reporting Services. I believe I mentioned this last week or the week before, where anyone who has been transferred over to an electronic health records also has had to use what we call G codes. And the G codes are related to PQRS. And these different G codes are based on the different healthcare systems or services. So physical therapists have their own G codes, chiropractors have their own G codes. And all these G codes are basically to report more information to Medicare. Now, if you're not using these G codes, you're still going to get an incentive payment because you have gone to electronic health records. But you're going to get more of an incentive payment if you are using your G codes properly. Because you're telling CMS that you're taking the time to document with these G codes the care that you are providing to these patients. So that's what it is. Physician Quality Reporting Systems or Initiative. In the book it's PQRI, but they changed it to PQRS. Okay? Recovery Audit Contractor Initiative or RAC originally created a demonstration program that became permanently implemented when Congress enacted the Tax Relief and Healthcare Act. It extended the RAC program to all 50 states by 2010. Its goals are to identify Medicare underpayments and overpayments and recover any overpayments using automated review and complex review. Not a good thing, okay? We talked a little bit, we mentioned earlier the RBRVSs. We'll talk more about that in the Buck book. This basically is what Medicare uses to come up with their fee service. Claim submission. Your local coverage determination was formerly known as LMRP. And your local coverage determination is an educational and administrative tool to assist physicians and providers and suppliers and whoever has the time to read one of those things to figure out how to bill. There's a local coverage determination out there for just about every single specialty and procedure known to coding. And if you have the time, you go Google it and you read it and then you say, what in the heck were they talking about? Because they don't write it all in real clear English. Your MACs and your FIs. Over on page 422. Your MACs are your Medicare administrative contractors and your FIs are your fiscal intermediary. Basically, your MACs are your contractors who oversee all of the Medicare claims. And they were your fiscal intermediaries are your home health agencies and your long-term care facilities. A provider identification number. What is a PIN, Lisa Fry?
It's the provider identification number.
Right. It used to be a UPIN number, and it's now called an NPI number. Your providers used to actually have to have a UPIN number for every payer that they credentialed and had a contract with. What they finally did was they made it so that every payer now has a 10-digit NPI number. And that is what identifies them to all of healthcare. Patient signature authorization You need this to transmit claims, your electronic claims. Time limit. The Healthcare Reform Act of 2010 changed the filing deadline for claims. Providers no longer have 15 to 24 months. They must submit claims within 12 months. Your paper and electronic claims, again, not many people do paper claims anymore. Your electronic claims, Medicare requests that all providers transmit claims electronically. Your patient signature authorization is also known as an SOF, or a signature on file. Your Medicare and Medicaid claims on page 423, bottom left-hand column. This is where Medicare crosses over to Medicaid. Medicare pays the 80% and Medicaid should pay the 20%. Your Medicare and Medigap claims, this is where Medicare is primary and the Medigap claims are usually the secondary payers like Federal Blue Cross. Basically any other health insurance that offers secondary coverage. There might also be a Medicare and employer supplemental insurance claim. Turn the page. We talked earlier about the Medicare supplemental secondary claims. Claims for deceased patients. There are two ways in which to submit billing for a patient who has died. You accept assignment on the claim, you submit it, and you make sure on there you indicate that the patient died on a certain date on block 12, or the non-participating physician does not accept assignment, bills Medicare, and submits the following. It tells you right there what you can do. Physician substitute coverage. Sometimes there might be circumstances where you need to get a physician to come in and fill in. So you want to have a reciprocal arrangement or a locum tenens arrangement. And when you're transmitting the claims to Medicare, make sure you have the correct codes in the right boxes. After claims submission, with your remittance advice, Medicare will send a payment check and a nationally standardized document to your physicians called a Medicare remittance advice, or an RA. The Medicare summary notice, this is what is mailed to the patients. So whenever a patient comes in and says, well, I don't know what I owe you, first of all, know for darn sure they do know what they owe you, because they get a remit in the mail just like you get a remit in the mail. It might not look the way yours looks, but then it says, and you might also be billed this by the provider. I know what the patient looks like because the patients bring them in and say, what does this mean? But all of your insurances send copies to their insurers. And if not, you can have access to it online. Beneficiary representative and representative payee. What is a beneficiary representative, Angel?
A beneficiary, it's somebody that sponsors somebody else that's not able to communicate or get to where they need to be to do their business.
Yep.
They oversee it. And it's sometimes it can be like healthcare.
Mm-hmm. Okay. That is it for chapter 12. Any questions? No questions? 5 minutes.
Out. Stay.
All right. Now back.
Yep.
Yep.
Okay. All right, let's turn to chapter 13, Medicaid and other state programs. So a little history about Medicaid. It was between 1933 and 1935 when the Federal Emergency Relief Administration made funds available to pay medical expenses of the needy unemployed. The Social Security Act of 1935 set up the public assistance programs, and in 1950, Congress passed a law mandating that all states set up a health care program of assistance, which meant that the states had to meet minimum requirements as a result of this mandate. We also had the Deficit Reduction Act, the Fiscal Responsibility Act, the Medi-Cal, the Patient Protection and Affordable Care Act, over on page 436, bottom column, and the Healthcare and Education Reconciliation Act. Some of your Medicare programs or Medicaid programs, the first one is Maternal and Child Health Program. This provides low-income mothers and children with quality care. It reduces infant mortality, increases your child immunizations, and assists in pregnancy care. It also offers preventative care, rehabilitation, and special needs. Your low-income Medicare recipients, also MQMB, the Medicaid Qualified Medicare Beneficiary Program, or the SLMB, the Specified Low-Income Medicare Beneficiary, or QI, Qualifying Individuals, over on page 437. 438, page 438, your Medicaid eligibility is broken up into categorically needy, medically
Excuse me,
needy.
Doreen. I
Yes.
just have to step out for a minute.
Okay. Maternal and Child Health Program eligibility, Spousal Impoverishment Protection Law, and the New Freedom Initiative. The New Freedom Initiative, actually, federal legislation passed in 2001. It aims to remove barriers to community living for people of all ages with disabilities and long-term illnesses. When you're accepting Medicaid patients, you should be participating in the program. You want to identify care. You also want to see their identification card, so over on page 440. They should give you some form of identification like you see it on page 441. Your point of service machine, when professional services are rendered, eligibility for the month must be verified, which may be done in a number of ways. That's the hardest part with Medicaid patients, is that you have to verify benefits on a monthly basis. There can be such a thing as retroactive eligibility, but you're going to have to find out when you call to verify benefits. Some covered services might be early and periodic screening, diagnosis, and treatment. Your disallowed services on page 443 would be again, finding out when you verify the benefits, what's covered, what's not covered, and then having a patient sign a waiver to hold them responsible. Your Medicaid managed care, states have actually brought managed care to the Medicaid programs, and what this does is it helps to control the escalating healthcare costs. It curbs unnecessary emergency department visits and emphasizes preventative care. So I don't know if any of you remember in the news where Medicaid owed thousands of dollars to the hospitals in the state of Maine. and the governor helped to get either most of it or if not all of it paid back. So the hospitals were not the only ones affected by non-payment. All of your small practices were affected by non-payment. And you really have to verify benefits on a monthly basis. Your claim procedures do not differ any different than any other claims that you send. So claim procedures on page 443 in your textbook. You have co-payment, you get prior approval, there's a time limit to file, and you have reciprocity. What is reciprocity on page 444, Angel?
Most states have reciprocity for Medicaid payments if a patient requires medical care while out of state. Contact the medical fiscal intermediary in the patient's home state and ask for the appropriate forms. If the case was an emergency, state this on the form. File the paper with Medicaid in the patient's home state. Reimburse will be at the state's rate.
At that state where they are or where they're from?
At the state that they are in.
The state that they're in.
Yeah. Okay, on page 446, after claim submission, same thing. You see a remittance advice. You can file appeals just like anything else. Your filing might be limited. Your pathway of appeal might be different. You just want to find out what are they. Okay, any questions? You guys are too easy to me. All right, TRICARE and Veterans Health Care. TRICARE is known as a beneficiary. An individual who qualifies for TRICARE is known as a beneficiary. So TRICARE basically started in 1966. It was CHAMPUS. It was created by Civilian Health and Medical Program of the Uniformed Services. In 1988, CHAMPUS Prime created as managed care plan option. Then in 1994, TRICARE became new title with 3 options. You have TRICARE Standard, which is your fee-for-service, TRICARE Extra, which is your PPO, and TRICARE Prime, which is your HMO. 2005, TRICARE consolidated into 3 regions. Okay, the West, the South, and the North on page 452. Your eligibility for TRICARE. Your active duty service members, your eligible family members of the active duty service members, your military retirees and eligible family members, surviving eligible family members of deceased active or retired service members, wards and pre-adoptive children, former spouses of active or retired service members, they must meet their requirements. Family members of active duty service members who were court-martialed or separated from their families for abuse. Abused spouses and children of service members. Spouses and children of NATO nation representatives. Reservists and National Guard members who activated for 30 or more consecutive days. Disabled beneficiaries under 65 years with Medicare A and B, and Medicare eligible beneficiaries in TRICARE for Life. Your TRICARE programs, you have DEERS, which is the Defense Enrollment Eligibility Reporting System. This is a computerized database that all of your TRICARE eligible persons must be enrolled in. Then you have the NAS, which is non-availability statement. This is a certification from a military hospital when it cannot provide care. In 2003, it was not needed for individuals in the catchment area about an MTF. The TRICARE standard on page 453 indicates that an ID is required for all dependents over the age of 10. You are not limited to using network providers for medically or psychologically necessary services. Care is usually sought at military hospitals closest to home or identified through the healthcare finder. Your authorized providers must be used. Pre-authorization is necessary for specialty care, hospitalization, and certain procedures. And deductibles and co-payments do apply. With your TRICARE Prime, on page 459, TRICARE Prime. Actually, I skipped over TRICARE Extra. For TRICARE Extra on page 459, there again the ID is required for all dependents over age 10. It is a PPO option. The network provider must be used. Pre-authorization is necessary and coordinated by your healthcare finder for specialty care, hospitalization, and certain procedures. There are deductibles and co-payments that apply. With your TRICARE Prime, it is a voluntary HMO option with an annual fee that is required. You have minimum 12 months of participation. PCM coordinates all of your care except emergencies. A referral from your healthcare finder required for use of a non-network provider. Pre-authorization may be necessary for some specialty care, hospitalization, and certain procedures, and you have co-payments and deductibles that apply.
Okay, I'm back. Sorry for that.
Okay, we're on page 460 in your textbook. Your TRICARE Reserve Select is available to qualified members of the selected reserve and their families. Again, this is similar to TRICARE Standard and Extra. Sorry, TRICARE Reserve Select is on page 461. TRICARE for Life, right-hand column of page 461. This is a supplementary payer to Medicare. I can tell you that TRICARE does not cover chiropractic. There is no separate ID card. There is no referral or pre-authorization requirements. Payment is based on the services provided on coverage by both Medicare and TRICARE. Your TRICARE Plus is your ID card and your DEERS enrollment being required. Enrollees must use the military treatment facility as a source of primary care. The same benefits as TRICARE Prime when using the military treatment facility, and access to your specialty providers at the military treatment facility are not guaranteed. On page 463, your TRICARE Prime remote program. This is for active duty service members only. They must live at least 50 miles from the military treatment facility. The same benefits as TRICARE Prime. There's no prior authorization for routine primary care. The PCM is the coordinator for all care except emergencies. And there's no out-of-pocket expenses for in-network services. For the supplemental health care program over on the right-hand side of page 463, this is for active duty service members and their designated patients. What this does is it enables your beneficiaries to be referred to the civilian providers when needed. And there's no deductibles or co-payments if the military treatment facility actually initiates a referral. Turn the page to 464 for the TRICARE hospice program. This is based on a Medicare hospice program. The life expectancy is 6 months or less, and it can cannot also receive care under TRICARE basic programs. It has to be one or the other. TRICARE and HMO coverage. The provider must meet TRICARE provider certification standards. The type of care must be a TRICARE benefit and medically necessary on page 465 in your textbook. The provider must meet TRICARE provider certification standards. The type of care must be a TRICARE benefit and medically necessary, and TRICARE does not pay for emergency services received outside the normal HMO service area. Your VA administration program, the Veterans Health Administration Program, in 1973, CHAMP VA was created. It's also known as the Civilian Health and Medical Program of the Veterans Administration. It is now called the Veterans Health Administration. This is for spouses and dependent children of veterans with total permanent disability. Must not be eligible for TRICARE Standard or Medicare A, and this is a service benefit program. You will have to have an ID card for all dependents over the age of 10. You will find that the benefits are similar to the TRICARE Standard for dependents of the retired and deceased military personnel. There is a freedom of choice in selecting your civilian providers, and you might see pre-authorization needed for some services. Your claims procedures are the same. You are just billing them. You're billing them electronically or on paper. They have to be filed within 1 year of service. If you look on page 472, you'll see an explanation of benefits from the VA. Just take a moment to look that over. On page 470, workers' compensation. For TRICARE CHAMP VA, when you're billed with a workers' compensation, after the benefits are exhausted, the beneficiary with the work-related injury or illness must file the claim with workers' comp carrier first. So same thing, after claim submission, the patient and the payer will get explanation of benefits. So the patient will get something, the payer will, the provider will get something. All right. questions? Okay. So, we'll start right back at the beginning, chapter 1. What is the role of an insurance billing specialist, Angel?
To collect the money for the doctor and what services they've provided.
Okay. What are some of the job responsibilities, Lisa Fry?
Collecting the money, data entry, getting all the demographics.
Okay. What are some of the qualifications I would look for a billing specialist, Lisa Leonard?
Going through this course, organization, computer skills, telephone skills, nice personality.
Yep. All right. What is medical etiquette, Barbara? All right, Lisa Fry, tell me what medical etiquette is?
I think it's being discreet, not sharing the information loudly. Is that right?
Pretty good. Medical ethics, Lisa.
Medical ethics. Following office procedure.
Yep, standard of conduct. Okay. All right, what would you consider to be a scope of practice, Emily? Okay. What do you think is the scope of practice? Your scope of practice as a certified medical administrative assistant. What would fall under your scope of practice?
Assisting with the process.
Yes. Assisting the doctor, assisting the patient, assisting with processing of the claims.
Being able to do anything, basically.
Pretty much, yes.
That they need you to do.
Because your title is Certified Medical Administrative Assistant. So if you take that word administrative, anything that falls under administrative. Okay? All right, chapter 2. Chapter 2 is about compliance, privacy, fraud, and abuse in insurance billing. All right? What is HIPAA, Lisa Leonard?
Sorry, I keep shutting it off.
That's okay.
I know I sign it every time I go to the doctor's office.
It is the Health Insurance Portability and Accountability Act. And basically what you're doing is you're authorizing them to use your information to bill your insurance and to share your information with other providers who may need it for continuation of care. Short,
Okay.
sweet. Okay? What is an authorization of release, Angel?
Oh, it's a signature from a patient that they're releasing information on like their chart or for them to be billed or other doctors if there's referrals.
Okay. What is an employee confidentiality statement, Lisa Fry?
It's stating that everything's got to be confidential. We're going to sign it. I can't spit it out.
That's okay. On page 31 in your textbook, an employee has been trained as an insurance billing specialist with employee responsibilities and authorization to access personal, medical, and health information. And as a condition of my employment, I agree to the following. I recognize that I am responsible for complying with HIPAA, which, if I violate, may lead to immediate dismissal from employment and, depending on state laws, criminal prosecution. Page 31 in your textbook. I will treat all information received during the course of my employment, which relates to the patients, as confidential and privileged information. I will not access patient information unless I must obtain the information to perform my job duties. I will not disclose information regarding my employer's patients to any person or entity other than the necessary to perform my job duties and as permitted under the employer's HIPAA policy. I will not access any of my employer's computer systems that currently exist or may exist in the future using a password other than my own. I will safeguard my computer password and will not show it if in public. I will not allow anyone, including other employees, to use my password to access computer files. I will log off the computer immediately after I finish using it. I will not use email to transmit patient information unless instructed to do so by my employer's HIPAA privacy officer. I will not take patient information from my employer's premises in hard copy or electronic form without permission from my employer's HIPAA privacy officer. Upon termination of my employment, I agree to continue to maintain the confidentiality of any information learned while an employee and agree to relinquish office keys, access cards, or any other device that provides access to the provider or its information. And if you think about it, all of that is pretty serious stuff. All right. Patients' rights to privacy on page 32. Lisa Leonard, what are some of the rights that you have as a patient?
Well, you have a right to privacy.
Right?
Your right would be that your physician would not discuss your information with another patient.
Okay, so a couple other things then. You have a right to request restrictions on certain uses and disclosures of your PHI, so page 32. You have a right to request confidential communication by alternative means on page 33. You have a right to access, inspect, and obtain a copy of your PHI. Okay? And you have a right to not include certain things when your information is released. On page 34, you have a right to request an amendment of your PHI. When you do that, you want to do it in writing so that it gets included in your records. You have a right to receive an disclosures of your PHI. So if your records are constantly being released somewhere, you have a right to request where those records have been requested from. And that looks like that's it. What are the obligations of the healthcare provider for training HIPAA? Page 35. As a provider, do you think it's the responsibility of the provider to train his staff, Lisa Fry?
Yes,
Why?
because not only HIPAA will affect, if I don't comply with it, it's going to affect him and his practice.
That's right. So on page 37, they give you a bunch of guidelines for HIPAA privacy compliance. Consider the conversations that occur throughout your office. Be sure to check in the patient medical record and in your computer system to determine is there any special instructions to contact the patient. Do you want to be contacted by email, telephone, whether cell phone or work phone? Patient sign-in sheets. Make sure you have patients sign a form acknowledging receipt of the NPP. Formal policies for transferring and accepting outside PHI. Computers are used for a variety of administrative functions. Keep your root username and password confidential and change them often. Over on page 38, it continues. What would be a business associate agreement over on page 38, Angel?
38. The covered entity was responsible and liable for all activities related to their business associates. If a covered entity becomes aware that there was a branch involving a business associate, the covered entity was expected to terminate the contract if the breach was not corrected.
Correct. All right. How about notification of a breach on page 39, Lisa Fry?
Defines a breach as the unauthorized acquisitions, access, use, disclosure of the PHI that compromises the security or the privacy of such information, except with an unauthorized person to whom which the information is disclosed, would not reasonably have able to retain such information.
Okay, very good. Over on page 40, fraud and abuse laws. What is fraud, Teresa?
Oh, gosh. Fraud is just submitting claims.
Yep, they give you some examples over on page 41.
Bill for service or supplies not provided, yeah.
Yep, a whole bunch of things. What is abuse, Lisa Leonard? Over on page 42.
Abuse means incidents or practices by physicians not usually considered fraudulent that are inconsistent with accepted sound medical, business, or physical practices.
Yep. Over on page 45, what are the 7 basic components of a compliance plan? Angel.
Compliance. What page is that?
Page 40.
I didn't hear you.
Page 40.
45.
Page 45.
Oh, wait. Oh, compliance program. A compliance program is a comprehensive set of policies, procedures, and guidelines designed to ensure that an organization conducts its business in accordance with applicable laws and regulations.
Perfect, that's good. All right, let's move on to chapter 3, basics of health insurance. Emily, tell me about healthcare reform on page 54.
Do you want to know why?
Why was healthcare reform necessary?
A growing percentage of Americans were not covered by private or government insurance. Employers had to pay estimated healthcare premiums and did not want to cut wages to cover these costs.
Yes.
Government reduced the deficit by keeping down increases in the Medicare and Medicaid program. Physicians and hospital costs were 10%. Inflation high-tech equipment, expensive medications, and so on. Patients spend more and more money for less and less care and cope with the system riddled with insufficiency, fraud, services, or equivalent.
Very good. Insurance contracts. Lisa Fry on page 56, insurance contracts. What is an insurance contract?
It's the first legal item of business handling medical insurance is the insurance contract, as known as a policy.
Okay?
A contract is a legal and binding written document that exists between two or more parties.
That's good. Okay? Managed care patients. Lisa Leonard, what is a managed care patient on page 57? I think you turned your volume down. Oh, you're funny. I can't hear you. Okay, good try. Poor Lisa. We can't hear you. I can't hear you. I can't hear you. Okay.
I'm done.
Okay. Okay, that's fine. I won't ask you
I'm
to
sorry.
repeat it. You can all read it in the book. A managed care patient is someone who is under an HMO plan. And your primary care physician is the gatekeeper of the HMO plan. All right, coordination of benefits. What is a coordination of benefit or a COB, Emily? Page 59.
Statement is, yeah, it's a statement that's included in most policies.
Right, a statement. Okay. What is a medical savings account or a health savings account on page 64, Lisa Fry, short, sweet, and simple?
It's when you put money in an account and you pull it out for medical expense.
Correct. Okay. Now, let's talk about page 68. The life cycle of a claim. Okay? Phase 1. Teresa, tell me about phase 1 and speak up so that others can hear you.
It's the patient's appointment and pre-registration, subject insurance information to obtain it and verify it. Then you give them the HIPAA notice of privacy, and the insurance identification card is photocopied, pay some signature requirements, assignment of benefits, and the patient's financial.
Okay, so I'm going to show you what that looks like. We're going to role play. So here's you've called on the phone, you've made your appointment, you've just walked in. I'm going to give you your paperwork. So, Teresa, welcome to our practice. I have some paperwork for you to fill out. Do you have your insurance card so I can make a copy? Yes, great, wonderful. So while I'm making a copy of your insurance card, I just have some forms here for you to fill out. And I will put the forms on the clipboard, and I will actually go over the forms with you. So this top sheet, Teresa, is really just the demographics. I need to get your name, address, phone number. I know what insurance is contributing to your care here. And then there is a front and back to all of these, so make sure you turn them over. And then on the back, I just need your health history, okay? Because we've talked about in the course getting personal health information. So here's some health history. You know, the doctor wants to know what you're coming in for today. And then over here, this is our waiver form. This is our consent to care, and tells you a little bit about our practice. Here's our HIPAA Okay, you can have this copy, but I really need you to sign this acknowledgement form so that I can keep that in our records. You can keep the HIPAA. And then this form here is what we call our body diagram, our functional index rating. So on this side, you're going to fill out on the body what's bothering you, and you're going to turn it over and you're going to tell me, how are you functioning? There's 10 questions here. When you're sitting, standing, driving, walking, from a scale of 0 to 10, how is the discomfort? What are you able to do? Just read these questions and go through it. And then this last page here, I forgot what the last page is. I'm trying to do it all from memory. But you get my point? This is what your phase 1, your pre-registration, the patient walking in, this is what you do, okay? Then you get, while they're doing that, you make a copy of the card, you hand them back the card, and then you take the card, and then afterwards, either while they're there or afterwards, you can call in the insurance and get the benefits, okay? But really, you're going over that paperwork with them. Not, here, fill these out for me, okay? You want them to understand what is required so that you get all the information you need. All right, phase 2 is where the medical service is performed, the encounter form is completed, the patient's financial data is posted, and the patient checks out. Phase 3. Phase 3. Tell me about phase 3, Lisa Fry.
It's an electronic claim, insurance claim electronically created.
Yep.
And then a claims transmission, provided signatures, and a track pending insurance claim via practice management software.
Okay. And what is phase 4, Lisa Leonard?
Payer processing payment received with explanation of benefits document and electronically posted.
All right, I'll cut you then. All right, thank you.
Bank deposit and unpaid claims followed up. Balance due statement mailed to patient. Full payment received and financial records retained. Could you hear me that time?
Yes, excellent job. Okay. So really the life cycle of the claim starts from the time that that person calls you on the phone to make the appointment or walks through the door to set up an appointment, because you're starting with all of their information. So wasn't part of the assignment to come back this week after someone had a doctor's appointment, and you were all going to, you were all supposed to see how the flow went, or remember? Or was I?
Yeah, I went and they told me my address.
Oh.
Yes, and then they asked me if my number was still such and such.
Actually, that's a good question. Now, with all these policies and procedures in the different offices, do you find that they're followed a lot?
No. No. I deal more specifically with the smaller practices, the single doctor, single staff, or single doctor, less than 5 staff members. And
Do you prefer that?
I do sometimes. Sometimes. It just depends, because you have those providers and staff who really want to, move their practice forward. And then you have the practices that are just stuck, literally stuck, can't get out of their own way, okay? So if the doctor is not, helping to get out of the rut, it's hard for the staff to help get out of the rut.
You find that
Yes, okay? Because these multi-physician practices or multi-physician, like your prime care associates, I'm not sure what else is up this way, but you know, Portland South is prime care associates, and I think Eastern Maine Medical just combined with what, CMMC here in the last year or so. Well, down south, Southern Maine
Medical?
Yeah, Southern Maine Medical Center. I get that confused with SMCC. They just combined with Goodall, and they became part of the whole Maine Health Network, which is part of, I believe, Mercy and Maine Health, right?
Yeah, I think
Okay.
Maine Med too.
So Maine Med, Mercy, Southern Maine Medical Center, and Goodall all have become this one big conglomerate of Maine Health. So what we saw as those smaller providers under Southern Maine Medical Associates, they then became Prime Care Associates. Now they're all Maine Health Associates or Southern Maine Health Associates. So you have all of these little, what I want to call satellite clinics everywhere, or offices, and you have physicians in the practices with multiple staff members. So they are held to accountability of policies and procedures and rules and regulations under the, you know, Maine Health umbrella. Whereas your small practitioners, the single staff, the single doctor, they're held to standards, but it's kind of like, oh, that's not going to happen. That kind of thing. So when an audit comes by, or the FBI walks in the door, or an auditor comes in the door, and it finally happens to them, they're like, oh my goodness. Okay? So they're being held accountable, they're just not recognizing it until it's too late. So part of my role in going in is trainer, consultant, accounts receivable cleanup or review, compliance officer, auditor, okay, all of that. So, okay, here's your book for class. Well, guess what? Here's your book for compliance. Here's your book for HIPAA. Here's your training manual. I'm basically going in and helping them to create all of this so that when they get an audit or are having an audit, they have it all in place. Because you're supposed to show you have a compliance manual, and you're supposed to show you have a HIPAA manual, a standard operating procedure manual. Your HIPAA training is supposed to be yearly. With all of this high-tech stuff and claims solution, you're supposed to, basically everything you do in your office, I kid you not, you should write it down. From the point where you go in and you turn on the light, to you turn on the equipment, you turn on the music, you prep the tables, whatever it is. You have a morning routine, you have a closing routine. How do you forward the phones? I have actually one staff member in one office who literally did that. She created her own how-to manual for the whole front desk, utilizing the software that we use. I'm like, I love you. And that just made my job that much easier because I didn't have to go behind her and recreate anything. I just said, tweak this here, tweak that there. And so for she has phase 1 and phase 2 in her how-to manual. Not in the work, but she knows that what she's supposed to accomplish in, say, the first 3 visits of the patient visit. And she has that written down. As the back office person, you know, office manager, biller, whatever you want to call it, The responsibilities range from, training, filling in, coming up with the compliance manual, coming up with the HIPAA manual. You said, Lisa, that they said to you, are you still at this address, this phone number? I know they probably don't have your picture in the computer, but that's where some of the EHR programs have actually gone to, where you can start taking pictures of your patients so that whoever's sitting greeting your patients can see who's coming in and know the name and the face so that you can greet them by their name. And that actually, for me, was really handy over the past 2 weeks where I filled in, because there were pictures to associate with the patient name, and I was able to greet them and introduce myself. Because I've been working with this practice now for years, and I know the names because I've been working with the accounts, but it's nice to put a name with the face. So you really want to hold yourself just as accountable as if you were in one of these larger places, because they have it all in place. My daughter right now is training, and she's going through a 10-week program, and her first week, they've already covered HIPAA and compliance for her. So wherever you go in these larger places, you're going to have HIPAA and compliance. Okay. All right, release of information, we've mentioned that. An insurance ID card, we've talked about that. What is an encounter form, Emily? Just tell me. You don't need to look at it. What's an encounter form?
It's a charge slip, multi-purpose billing form.
Right, it's a charge slip, fee slip, whatever you call it. Okay, let's move on to chapter 4. We're talking about medical documentation and the electronic health record. What are electronic health records, Angel?
The connection between insurance billing and the health record, also known for decades as the medical record, should be explained to better understand its importance in the tool of clinical care and communication.
Yes.
It's written or graphic information documenting facts and events during the rendered of patient care.
Good. On page 89, disadvantages of electronic health records. Give me some disadvantages, Lisa Fry.
It's the startup cost.
Okay. What are some documentation guidelines for medical services? I won't go into that, because we'll go into more of that later on. Review of systems. What is critical care? What is critical care? Lisa Leonard on page 106.
Life-threatening condition.
Yes. On page 113, what is an external audit, Teresa?
External audit is a retrospective review of medical and financial records at the request of the physician, an outside contractor, insurance company, or an external reviewer as part of the practices and compliance plan.
Perfect. How many years should I retain employee contracts on page 119? How many years should I retain employee contracts? Angel?
4 years? No, that's the accounting one.
Employee contracts should be, how about 6? Employment applications are 4. All right. Chapter 5 we didn't do because why?
We're going to review further in the buck book.
Yes.
Diagnosis.
What is a diagnosis? Emily?
Given you one, don't
Right. A diagnosis code tells the payers what's wrong with you.
Yeah.
A procedure code is what, Lisa Fry?
What they actually did.
Correct. On page 265, the electronic claim. What is EDI? On page 265, what is EDI? Lisa Leonard.
Electronic data interchange.
Yes. On page 266, what is a clearinghouse? Angel.
Let's see. Is an entity that receives the electronic transmission of claims from the healthcare provider's office and translates it into a standard format prescribed in HIPAA regulations.
Okay. And what on page, let's see. What are the signature requirements on page 281 for the physician? Page 281, signature requirements for the physician, Teresa.
The physician's signature on the agreement or contract with third party here is a substitute for the signature.
Yes. Okay. All right, chapter 9, receiving payments. Page 298, what is an explanation of benefits, Lisa Fry?
It may also be referred to as a remittance, advice, check voucher, or payment voucher. It is a document issued
Yes.
stating the status of a claim.
That's good. Okay, claim management techniques. Give me 3 claim management techniques on page 301. Lisa Leonard. You don't have to tell me what they are, just tell me 3 things.
Oh. Insurance claim register.
Yep,
Tickler. Aging
Yep.
reports.
perfect. All right. What are some problems, what are some of the types of problems with claims on page 304? Angel.
Overpayment, downcoded, lost, rejected, delinquent, pending, partial payment, or payment was lost in the mail, payment
Okay.
paid to the patient.
All right. Over on page 307, rejected claims. Give me 3 things why claims might be rejected. Teresa.
Transposed numbers, missing required help, HIPAA transaction codes, missing subscriber date of birth, invalid place of service, mismatch of place of service to type of service.
Okay, excellent. That's good. Rebilling. What is rebilling, Emily? Um, 313. Rebilling.
claims not received, automatically rebilled, repair without research.
Okay. Rebilling basically, a claim is denied, we've corrected it, and we can rebill it. on page 315. What are the 5 levels of Medicare review and redetermination process on page 315? Lisa Leonard.
Level 1, redetermination. Level
Yep.
2, reconsideration. 3, administrative law judge. 4, Medicare appeals council. 5, federal district court.
Perfect. Chapter 10, page 333. What is the AR? On page 332, what is the AR, Teresa?
Aging report.
4,
Okay, I'm sorry, accounts receivable,
and it includes?
the unpaid balance.
Perfect. What is a patient registration form, Emily?
It is. Let you fill out. Start now.
Yeah. On page 335, fee adjustments. Tell me some fee adjustments, Angel.
A discount or reduction of normal fee based on a specific amount of money or a percentage of the charge.
Yep.
So if they like co-payments or co-insurance.
Mhm. On page 337, what is the professional courtesy guideline, Lisa Fry?
The code of ethics, medical ethics.
Nope, on
I'm on
page
the wrong.
337, the professional courtesy guideline, bottom right-hand corner.
Is a concept attributed to the, what does that say, hypocrite?
Nope, it's professional courtesy may violate fraud and abuse laws depending on how the recipients of the professional courtesy are selected and how the courtesy is extended. If selection depends on referral of individuals, then it may implicate the anti-kickback statute, and insurance claims submitted as a result of such a professional courtesy may also be affected by the False Claims Act. All right, page 339, collecting fees. When do we want to collect fees? Angel.
As soon as they hit the office, the copay and whatever their insurance doesn't cover.
Yeah. All right, what about credit arrangements on page 348, Lisa Leonard? Page 348, what should we do about credit arrangements?
Well, you have options for the credit arrangements.
What would you suggest if I came to you? What would you suggest?
I would need a credit card with IDs.
Perfect. All right, page 350. Let's talk about red flags rule. The red flags rule on page 350. What is the red flags rule on page 350? Lisa Fry.
The red flags rule is a set of Federal Trade Commission requirements for businesses that have more than 20 employees and issue credit to their clients.
Perfect. Okay, what is an office policy on page 353, Teresa?
Office policies determine which collection costs. Print out the accounts receivable by age and charge the accounts that are in the 60-90 category.
Okay. Emily, what is a copay? Okay. What is a co-insurance?
Oh, me?
Yep.
Sorry. It's B, if you have one or more insurance. That
Okay.
work together.
Here's an easy way to remember copay versus co-insurance. Copay is usually a set dollar amount, like 15, 20, 25, 30, 35, 40. That is a copay. Your copay is due at time of service, okay? A co-insurance is your responsibility of what the insurance will not pay. So if your insurance pays 90, you're responsible for 10. If they pay 80, you're responsible for 20. That can also be collected at time of service. You just have to find out. What most patients are not aware of is that their contract with the insurance, believe it or not, you are supposed to be paying your co-pays and your co-insurance is at time of service. When that contract was signed, whoever the subscriber was and the insurance, so my husband signed a contract with his employer with our health insurance plan. We are obligated to be paying our co-pays and our co-insurances at time of service. So when a patient comes in and says, oh, I can't pay today, you can remind them nicely that it is their obligation with their contract with their insurance company.
That's one thing I don't have to do is if somebody comes in, they don't have to do the copay with the insurance. How much money is there? What if there's a person that can't answer the question as far as how much that office visit would cost if they had something done like that scrub test, you know?
Well, sadly, I didn't think.
But how do they figure?
They're supposed to be able to figure it out. Usually what I tell people who can't do that type of stuff, or they can't see it, it's not tangible for them, so they just don't, they're not sure, I'll say, okay, take the total charge, multiply it times 20%, and collect that from the patient. Because you haven't verified the insurance yet. We don't know what the insurance will cover. So what I say to the patient is, all right, Teresa, your insurance pays 80%, you're responsible for 20% today. Our charge is $50. 20% of that is, this is your responsibility, okay? Now, if the insurance comes back and they have paid less than that, you may have a credit on your account, which we will just carry forward to your next visit. How does that sound?
That sounds good, but like, I think the question is like, you go into office, that, right? Is that amount figured?
No.
Before it gets to the.
No. Most people, when you go check out, the only thing they're concerned with is your copay or your co-insurance. That's it. They will send you a bill for the other stuff. Okay? Not everyone.
So that co-insurance is usually based on the visit
Yes.
amount.
Office visit and because your strep usually goes out to a lab. If they do it in the office,
I'm just trying to make sure scenarios they do in the office that, how would you come up with an amount or something?
right.
Or goes to the front desk, charge that person.
What I usually do in that instance, and in the chiropractic setting, we have those instances where the patient has a copay for the office visit, which is the E&M, and then they have a co-insurance for x-rays and the adjustment and anything else. So, yeah, they have to figure out, all right, they have a $25 copay, but then they have 10% co-insurance for everything else. So, if we don't have the insurance verified, I just split up with excluding the E&M, because I know I'm collecting 25 for that E&M, and then I would 10% of the total of the other charges.
And that's just your policy established with
Yes.
that business.
Yes. And once the claims come in, and I have posted to the account, if the patient has overpaid in 99% of the time they have, that small credit gets moved forward to their next visit. So I'll say, Teresa, your insurance is posted. you now have a credit of $2.52. So today you only owe me $4.68. How does that feel? Okay, so we're always collecting something every visit. And that's how I tell staff to treat it. We just, once we bill your insurance, we will know exactly what to collect. Now, you always have those patients who come in and say, well, I know that I never pay more than $6.71. I'm not going to pay more than $6.71. So then you collect $6.71, and once the agreement comes in and you post, you let the patient know if it changed or not. You also have the plans out there where the HSAs and the MSAs, the reps are telling the patients that they cannot be paying upfront. And the reason they're telling them that is because they don't want the patients to be paying more than what they're supposed to. So if the allowed amount is $37.98 and the patient's responsibility is $5.69, but we figured the 10% on $45, then we've collected too much. So on the HSAs, if I don't know the exact amount, I might not collect. And what I'll say to that patient is, because you have an HSA account, I know that they're very particular about you paying at time of service the exact amount. So let me go ahead and get the remits. Once the insurance posts, I'll let you know exactly what you owe me. Okay? All right, so that's review for tonight. I think we reviewed right up through, what, 11? Okay, and let me give you your assignments. So it's 12, 13, and 14 I'm assigning tonight, right?
Yep.
Okay. Okay, let's do fill in the blank on page 240 in your study guide. Page 240. Page 241 and 242. All right, 13, chapter 13, to page 295, fill in the blank. Page 296, all of it. And 297. And then chapter 14. Page 320, fill in the blank.
What was that? I didn't get the number.
Page 320.
320, thank you.
Page 321. And page 322. And let's see. And that should be good. So for tonight, Lisa Fry, what is your takeaway from tonight?
That there's a whole lot to learn about Medicare.
We just hit the tip of the iceberg. All right, Angel, what's your takeaway?
There's a lot of different health insurance and information that you've got to collect and verify to make sure like pre-authorizations and there's certain doctors that like take part in the participation, and then there's non-par, and there's a lot to it. It's just a lot.
There is. Lisa Leonard, what's your takeaway?
That I need to learn how to use this thing better.
Good job. Barbara Hankey, are you still with us? I don't think so. All right, and Emily, what's your takeaway?
I had no idea what a co-insurance was until tonight. I thought it was your secondary insurance for some reason. I got that confused.
Well, it can be.
Oh,
It can be. With Medicare, remember that Medicare pays 80% and the patient would be responsible for 20%.
Yeah.
So if there is a secondary, the secondary is supposed to pick up that 20%.
Okay, yes, there's the,
So you're
that's
on
where
the
I'm getting
right,
confused.
you're on the right path. Okay. Teresa?
And lately, you see there's a lot of different insurance companies and policies. I think it'd be kind of, I don't know if we can do this or whatever, but just to show us how to set up our information sheet for one person to get kind of a feel of what we're looking for from the insurance companies.
Yep, we're
in
gonna
our
do a
own
claim
personal
form.
book. But like, you know how you said you have a personal binder that you set up and you can look at the insurance company and see what they pay under
Oh,
this
yep.
coverage and that coverage?
Yep.
Just to have that all in front of us and where to go to look for that
Okay.
and how to look for it.
Yeah, we can do that. Okay. So, my takeaway from tonight is not so fast. And you probably have noticed I stand here and I sway. I cannot stand still. I have a hard time standing still.
I don't
Okay, so I'm trying really hard this semester not to walk around because last semester I was walking around a lot. I was pacing back and forth. So that's why I have this here so I can kind of grab onto it and not move too much, but I still sway. So I apologize up front. So this time next week, have a great week, everyone. Just so you know, I'm going to remind you now, the last week of November is Thanksgiving. There will not be classes that I'm aware of. I will double check. And
Do we need to bring any books, other books with us next week?
next week we're going to finish up the Fordney book, and we'll probably go through a claim form. I'll bring some claim forms, but you also have claim forms in your books. And I'll try to get a easel or whiteboard in here that I can write on so everyone can see. But was the volume okay? Was I yelling too much? Because I'm across the room.
No, you sound fine.
Okay, excellent. All right, have a great week, everyone.
Bye.
Thank you.
You're welcome.